Good morning. I'm Tom Delaney. I'm the Andres Soriano Professor of Radiation Oncology at Massachusetts General Hospital. Today we're going to be talking about chordoma, which is an uncommon tumor, only about 300 cases per year in the United States. To put that in context, there are approximately 250,000 cases per year of breast cancer. These tumors occur anywhere along the spinal axis, most commonly in the sacrum, and then less frequently in descending order at the top of the spine with the skull, called the clivus, the cervical spine, the lumbar spine, and then the thoracic spine is the least common site where these arise. These tumors are felt to develop from the embryologic precursor to the spine. This is referred to as the notochord. Men are more commonly affected than women. A small proportion of patients, about 5%, will actually have other prechordomas, which are called benign notochordal tumors that either need to be monitored or evaluated at the time of the initial assessment. More rarely, another chordoma is arising along the spinal axis. So when patients are initially evaluated, we obtain an initial MRI of the entire spine, which extends from the base of the skull to the bottom of the spine as part of the initial evaluation. There are four types of chordoma, two that are favorable, which are referred to as the conventional and chondroid chordoma, and two are unfavorable. One is referred to as dedifferentiated chordoma, and the other is poorly differentiated chordoma. The poorly differentiated chordomas occur in pediatric patients, and these unfortunately have high rates of spread to other parts of the body. The dedifferentiated chordoma arises in adults and also has a very high risk of spread to other sites of the body. It's very important, thus, to have the pathology reviewed at a center that sees a lot of chordomas to confirm the exact chordoma subtype that a patient has. These tumors tend to infiltrate the tissues around the site where they arise because of this biologic behavior, as well as the fact that they arise in close proximity to major nerves such as the spinal cord, as well as the nerves at the bottom of the spine called the cauda equina and the sacral nerves. And these nerves are critical for a number of body function in the chordomas that arise in the sacrum. For example, the sacral nerves innervate the bladder and the anal sphincter. So if there's damage to those nerves, patients end up losing normal bladder and or anal function as well as erectile function. Because of the infiltrative nature of these tumors, it's often difficult for surgeons to widely excise these as would be appropriate treatment for other spine tumors. Hence, radiation is added to surgery to reduce the likelihood of the tumor regrowing after surgery. When radiation is used, these tumors require high radiation doses. The advantage of using proton radiation is that compared to X-rays, they travel only a defined distance in tissue, and up to 50 to 60% less normal tissue adjacent to and beyond the tumor is irradiated. Metal stabilization hardware, however, can affect the proton dose. So if there's spine hardware in close proximity to the tumor, some centers will not treat with protons, although we've been able to combine X-rays, which are less affected by metal, delivered as what's referred to as intensity modulated radiation therapy in conjunction with protons. In some locations, such as the upper sacrum, surgical removal of the tumor, in fact, will damage the nerves responsible for normal bladder, erectile, and anal function. If the tumor has not already damaged these nerves, some of these patients have been treated successfully non-surgically with protons or carbon ions. Carbon ion is a charged particle like the proton, but 12 times heavier. And in fact, the majority of patients treated in this fashion are able to have their tumor controlled. Carbon ions are only available at the current time in Japan, China, and Europe, but the results with carbon ions seem to be very similar to those achieved with protons. For some patients, this treatment without surgery with protons alone can be a very important treatment option. As I mentioned, proton is preferred for treatment of chordomas since the most experience with the treatment of chordomas is with protons, and they reduce the radiation dose to the normal tissues such as the bowel and kidneys in front of the spine. And this should reduce, or if those tissues get no radiation, in fact eliminate the risk of radiation injury to these normal tissues. If all visible tumor is removed, the recommended radiation dose for chordomas is in the range of 70.2 gray in 39 treatments over 8 weeks. If there's visible residual tumor that could not be removed, or if the patient is being treated non-surgically, the radiation dose is about 10% higher, 77.4 gray in 43 treatments over 9 weeks. Some centers, such as ours, treat with some proton radiation before surgery, followed by additional proton radiation after surgery, to reduce the risk of tumor spread that can occur with some types of surgery. In addition to being locally infiltrative, these tumors, unfortunately, can also spread to other parts of the body, although in only about 20% of patients. Hence, as part of the baseline evaluations, patients will need to undergo a CT scan of the chest, abdomen, and pelvis to make sure that the tumor has not already spread to other parts of the body. I think at this point we'll digress for a moment and review the potential short and long-term side effects associated with the treatment for chordomas. Specifically, with regard to surgery, you'll need to discuss the risks of surgery with your surgeon. The risk for surgery will depend specifically on the location of the spine where the tumor is located, as well as the planned surgical procedure. The short and long-term effects of radiation depend in part, again, on the kind of radiation, proton versus X-ray, with proton expected to have fewer side effects, as well as the radiation dose needed, which varies according to how much tumor remains after surgery, and then most importantly is the location where the chordoma is located. It's important to realize that the biggest risk faced by the chordoma patient is either the local recurrence of the chordoma at or near the site of origin, which in some reports is unfortunately as high as 50% 10 years after treatment, with the combination of surgery and post-operative radiation, as well as a risk of metastatic disease of about 20%, usually to lungs, liver, and to bone. In our experience, patients who receive a component of pre-op radiation, in fact, have much better local control of tumor, which is why, if you've not had surgery already, we often do start with some radiation before surgery. As I mentioned, preoperative radiation as well as removal of the tumor in one piece appear to reduce the risk of a local recurrence. A local recurrence of a chordoma can cause pain, nerve injury, or other possible complications from tumor growth. Spread of tumor to other parts of the body can unfortunately lead to side effects including death related to progressive tumor growth in the lungs or liver, or pain from spread of tumor to the bone. Chordomas, however, when they do spread, often grow slowly, and in fact patients may be able to live for years with a chordoma that has locally recurred, or even if the tumor has spread to other parts of the body, although they may in fact have symptoms related to the tumor. Returning to the potential side effects of radiation, the general side effects of radiation include those which we refer to as short-term, which are those that occur during and around the time of treatment. Fatigue, generally mild. Patients may have some nausea, but in most patients it's usually well controlled with anti-nausea medications. Patients will develop some redness around the area that's being treated, some redness of the skin, and occasionally there may be transient irritation or peeling of the skin overlying the area of the tumor that's being treated. Depending upon the location of the tumor, such as tumors that are rising in the neck, there may also be some transient irritation upon swallowing related to the radiation treatment. Patients can also have what we refer to as late effects from radiation. These can occur at any time after 3 months of treatment, and in fact, unfortunately, can occur years later. Some of the side effects that can occur include one which is referred to as fibrosis, which is the firmness of the subcutaneous tissues and muscle in the radiation field around the area where the tumor was treated. While radiation injury to the kidneys, liver, small bowel, and large bowel can occur, they're extremely uncommon with proton radiation, as I mentioned, which in general spares these tissues. The involved spine where the chordoma arises can be weakened by the tumor, by surgery, and by radiation. In fact, it's possible for spine bones after receiving high dose of radiation to collapse, so those bones need to be monitored after treatment. Also, radiation can affect what we refer to as the spine fusion after surgery. This is usually a construct involving a combination of bone, a cage, and metal hardware. And if there is an impact of radiation on the spinal fusion, this can result in some motion of the spine that causes metal fatigue in the spine hardware, which in fact may break, requiring additional surgery to replace the spine stabilization hardware. Radiation injury to the spinal nerves causing pain, weakness, difficulty with bladder rectal control or paralysis are rare complications. With the use of protons, this is extremely uncommon. A radiation-induced tumor in the area that's radiated is a very serious but fortunately a rare complication of high-dose radiation. This rarely occurs before 5 years after treatment, but it may occur even up to 20 years after treatment. Nevertheless, it's expected to be seen in fewer than 1% of treated patients. Patients often ask after treatment, how do we know that the chordoma has been controlled? We follow the patients who have been treated for chordoma with periodic scans. What we plan for most patients is doing MRI scans of the area where the tumor arose every 6 months out to 5 years. During this time interval, we also obtained chest imaging, usually alternating a chest X-ray with a chest CT scan out to 5 years. Similarly, we take plain films of the spine to monitor the spine fusion and the spine hardware. After 5 years, we decrease the frequency of follow-up to yearly. And then even after 10 years, though, we tend to continue to follow patients at least every other year. The most important thing to remember about chordoma is that they're the best chance to control a chordoma. And in fact, in some cases, the only good chance to control a chordoma is at the time of initial surgery and/or radiation therapy. Hence, it is absolutely critical that the surgery and the proton radiation be done by physicians highly experienced at treating chordoma. The importance of this cannot be overemphasized. Thank you for your time today.